Hello and welcome. You're listening to the Sickle Cell Action Network, a weekly internet radio show presented by Martin Center Sickle Cell Initiative and sponsored by Mass Therapeutics. We're coming to you live from Indianapolis, Indiana, and we're here to serve you by providing up-to-date information and opinion on all matters pertaining to sickle cell disease. My name is Gary A. Gibson, and I am your host for the next 2 hours. Let me start by saying that I don't have sickle cell disease, nor do I carry the sickle cell trait. In spite of that, I am no stranger to sickle cell. Quite the contrary. You see, even though I don't have sickle cell, it has had a very huge impact on my life. That's true because its complications took my wife from me after 12 years of marriage. It also caused her to have a miscarriage that resulted in the loss of our twin babies that she was carrying while in a sickle cell crisis. So all told, sickle cell has taken 3 lives from me, and I feel the pain of those losses every single day. I currently serve as the president and CEO of Martin Center Sickle Cell Initiative, a community-based organization that has been serving people with sickle cell for over 45 years. Each day I attempt to transform the pain of my losses into positive energy that is focused on making a difference for those who are battling sickle cell. From being involved with sickle cell for over 40 years, I'm able to say that much progress has been made, but there is still so much work to do. This show is an opportunity to contribute to the ever-expanding dialogue about sickle cell that is taking place all around the world. Our show is about raising awareness, but it is also about so much more. I like to say that sickle cell awareness is important, but we need more than awareness. Those living with sickle cell are already aware. That makes me ask, so what are we doing for them? My answer is not enough. That's why we've named this show the Sickle Cell Action Network, because awareness without action has very little impact. We want this show to be a source of information and a call to action to those who must live with sickle cell in their midst. We have designed the show to provide information that is beneficial to patients, caregivers, family members, and friends alike. Most importantly, we want people with sickle cell to know and understand that they are not alone. The Sickle Cell Action Network show features live guests who are healthcare providers, patients, advocates, and others who are engaged in the fight to eradicate sickle cell and ease its burden on those it affects. Today we are honored to have 4 very special guests, to talk to us about transitioning to adult sickle cell care. Joining me in studio today are Dr. Monica Khurana, a pediatric hematologist at Riley Hospital for Children at Indiana University Health, Ms. Kori Singleton, the parent of a young man with sickle cell, Peter Richardson, a young sickle cell warrior, and his mother, Sheryl Richardson. We're honored and thrilled to have them with us today. Before we get to today's topic, however, I want to share some of our upcoming topics with you so that you'll know what we are going to be up to. In future weeks, we will cover such topics as depression and sickle cell, medical complications with sickle cell, the global state of sickle cell research update, celebrity advocates for sickle cell, connecting the sickle cell community, and so much more. So as you can see, we are serious about sharing valuable information, and we hope that you will join us every week, same time, same station. If you've missed some of our previous editions or wish that you could listen to them again, don't worry. Just go to the Martin Center Sickle Cell Initiative YouTube page and you'll find them there. Now let's get on with our show, and we'll start with this week's edition of Sickle Cell News Update. My first story today is an inspiring story about researchers who are working on something called gene editing. And this story comes to us from the Valley News in San Jose, California. And it's a story about work that's being done at Stanford University. And basically the story says, until recently, gene therapy was laborious, crude, and unsafe for human testing. But a new technology called CRISPR-Cas9 acts as a microscopic scalpel, performing genomic surgery with precision, efficiency, and affordability once thought unimaginable. The research being done at the Stanford School of Medicine, led by Dr. Matthew Porteous, is part of an accelerating research movement made possible using the new technique to try to cure genetic diseases such as sickle cell anemia and muscular dystrophy. These labs are steadily advancing through cell-based and animal trials as fledgling biotech companies raise large sums of money needed to bring the therapies to market. Now, with lots of people, hundreds or thousands of labs working with CRISPR, this means the possibility of actually finding a way to cure patients of diseases increases dramatically, said Dr. Porteous, an associate professor of pediatrics and a pioneer in gene editing. Using the campus's first ever cell manufacturing plant to be completed this spring, the Stanford team aims to start human trials in 2018. The researchers are targeting 2 severe blood diseases, sickle cell anemia and beta thalassemia, as well as several diseases that ravage the immune system. CRISPR, the technology that's being used, stands for Clustered Regularly Interspaced Short Palindromic Repeats, or clusters of brief DNA sequences that read similarly forward and backward. They say CRISPR is a game changer. This technology is only 3 years old, but if it works like and it sort of works like the search and replace function of a computer. So this story is promising, with research being done at Stanford University using CRISPR technology, which is used to edit genes. Another story that we'd like to share with you today comes to us from Nigeria. And this story says that over 150,000 children are born every year in Nigeria with sickle cell anemia. The Sickle Cell Club of Lagos has called for research into various fronts, especially on the immediate causes of severe pain crises in people living with the disorder. President of the club, Ms. Ayo Otagibi, who spoke during the annual celebration, said despite many medical advances, sickle cell disease is still not well understood. She said that research should take care of the rational therapy so that not simply analgesics can be applied with the objective of effectively aborting or preventing their occurrence. Noting the high burden, Otagibi decried the apathy towards people living with sickle cell in Africa. She said that part of their plans for 2016 are to consolidate on successes that they have recorded, as well as to increase the level of awareness of services at the National Sickle Cell Foundation and other health facilities in the country. Further, she said the club would continue to draw attention to the importance of transcranial Doppler scans in children with sickle cell in order to reduce the incidence of strokes in affected children. So, continual progress being made in Lagos in Nigeria. This story I'm very happy to share. Our sponsor, Mass Therapeutics, reported on January 7th that their enrollment in the pivotal phase 3 EPIC study that basically is our sponsor, said that they have now reached the level of 90%. They have targeted the number of people that they needed for their clinical trial, and they are now at 90% of that number. MAST expects to complete patient enrollment in February, and consistent with prior guidance, the company expects to report top-line results in the second quarter of 2016. So we're going to be seeing those results pretty quickly. According to Mr. Brian Culley, who did appear on our show a few weeks back, he says, "We are pleased to report that more than 90% of the planned 388 patients have been enrolled in EPIC, the largest sickle cell crisis intervention study ever conducted." Mr. Culley also said participation in EPIC has been outstanding, with more than 75 sites in 14 countries and more than two-thirds of those sites located in the United States. We expect to complete enrollment next month, and after the final enrolled patient's 30-day observation period, the process of blinded data review and quality control will begin, leading thereafter to database lock and unblinding of the study data. So thanks to Mass Therapeutics for being our sponsor, and also glad to share the good news that they are over 90% now of their goal. And finally, I'm really happy about this. This is a story that appeared on January 5th in the U.S. News and World Report, which is, a very major publication, and they have a story in there on sickle cell, and that's cool. It's in their health edition, but basically their story is about sickle cell disease and cold weather, the do's and don'ts, and it is written by Dr. Deepa Manwani, who is a director of the hematology program. She's an attending physician, a pediatric hematologist, just like our guest, Dr. Khurana, today. And she is at the Children's Hospital of Montefiore, and she's an associate professor of clinical pediatrics at the Albert Einstein College of Medicine, both in Bronx, New York. And according to Dr. Manwani, she's talking about the things that we're all pretty familiar with, but I want to read quickly the do's and don'ts, especially since it's very cold right now here in the Midwest and in other parts of the country. So according to Dr. Manwani, here are the do's. Dress warmly, but in layers, and carry an extra pair of dry socks. Stay hydrated. Drinking hot cocoa or herbal teas can be great. Carry and use a hand sanitizer frequently. Consider shopping online so you don't have to go out. Minimize continuous exposure to cold and windy weather or wet snow. Get plenty of rest and sleep. Minimize stress. Know your body and your limits. Make sure you have pain medications handy to start early in the event of a pain crisis. According to Dr. Manwani, here's a couple of the don'ts. Don't forget your hat, gloves, and scarf when you step out. Don't visit with people who have a cold or illness if possible. Don't drink too much coffee or caffeinated tea since it can contribute to dehydration. Don't get carried away with the ice skating, sledding, or building a snowman. Thanks to U.S. News and World Report for providing some sickle cell awareness in its publication, and thanks to Dr. Deepa Manwani for contributing to the article. With that information, we're going to go ahead and take a break, and when we come back, we're going to begin our great discussion about transitioning to adult sickle cell care.
Hi, I'm Gary A. Gibson, your host for the Sickle Cell Action Network Internet Radio Show. If you are impacted by sickle cell disease in any way, whether you are a patient, a caregiver, or a friend, you need to join me every Tuesday at 4 p.m. Eastern Time. I promise that you will find our show to be full of information, perspective, and opinion about all things sickle cell. See you Tuesday right here on RadioNext.tv, the Cool Groove site.
Welcome back to the Sickle Cell Action Network Internet Radio Show. My name is Gary A. Gibson. I'm your host. The Sickle Cell Action Network Internet Radio Show is brought to you by Martin Center Sickle Cell Initiative, and we're sponsored by MAST Therapeutics. MAST, based out of San Diego, California, is sponsoring the EPIC study, and it is a clinical trial. And if you know of someone, or if you yourself have sickle cell disease and you are interested in participating in the EPIC study, just go to www.theepicstudy.com for more information. I'm really excited about our show today. We're going to be talking about a very, very important topic, and the topic is transitioning to adult sickle cell care. My guests are Dr. Monica Khurana, who we will now refer to as Dr. K, Ms. Kori Singleton, and Peter Richardson and Sheryl Richardson. These folks are going to give us information today about transitioning to adult sickle cell care. As always, I like to start by letting my guests tell you a little bit about themselves so that you can get a sense for who they are and where they're coming from. And we're going to start with Dr. K. Dr. K, if you would, please tell us a little bit about yourself. Where are you from originally? Where did you obtain your medical training? How long have you been practicing hematology?
Thanks, Gary. First of all, thanks for providing this opportunity to discuss such an important topic for the sickle cell community. I became interested in hemoglobinopathies like sickle cell when I was a medical student at Indiana University School of Medicine. I completed my postgraduate training at Emory in Atlanta, specifically the Children's Healthcare of Atlanta, which has the largest comprehensive pediatric sickle cell disease program in the country.
Yes, it does.
To further broaden my experience, I moved to the San Francisco Bay Area to be under the tutelage of experts at UCSF Benioff Children's Hospital, Oakland. Wanting to honor the community that inspired me, I returned to Indianapolis to join the Department of Pediatric Hematology Oncology at Riley Hospital for Children in late 2014 to solidify and expand the sickle cell program.
Thank you so much. We're glad you're here. You're making a really big difference. Kori, you were on the show last week and you did such a good job, and you told us that you could talk about transitioning for days, so we invited you back. But go ahead, if you would, because we might have new listeners this week. Tell our listeners a little bit about yourself. Where were you born, and what do you do for a living?
I was born in Phoenix, Arizona. I am an independent accounting contractor. I moved here 3 years ago because I decided I wanted seasons. And boy, have we had seasons, so it's been wonderful.
Are you regretting that now?
I am not regretting it. As a matter of fact, I'm so happy to see snow. It almost made me regret the change.
Oh, okay. And Peter, tell us a little bit about yourself. Where were you born? How old are you? And what is your hemoglobin type?
Well, I am actually a sweet person, and I was born in Indianapolis, Indiana. I am actually 25 years old, and my hemoglobin type is SS.
Sickle cell SS.
Yeah.
Okay. Did I hear you say that you're going to be 26 pretty soon?
Yep.
How soon?
March 4th.
March 4th? You'll
Yeah,
be 26.
March 4th.
Great. And Sheryl, Peter's mother, tell us a little bit about yourself. Where are you from originally, and what do you do for a living?
I am born and raised here in Indianapolis. I work for the city of Indianapolis. I am the senior manager of community relations for Indy Parks.
Excellent. Excellent. Okay. Well, let's start by putting Peter on the spot. Peter, as a patient, you've experienced a few of the complications that are often associated with sickle cell, including having a stroke when you were very young. Would you tell us a little bit about what having sickle cell has been like for you?
Well, there's the good and the bad, so I might as well start with the bad. I actually don't like being in hospitals anymore. I used to when I was 10 years old and stuff. So as I grew into it, I realized that I'm going to hospitals and I'm getting blood transfusions every 5 to 6 weeks. So it's once I'm in a hospital, it's I'm not comfortable. I'm not comfortable sitting in the chair for what is 2 hours.
A little bit longer.
Yeah, a little bit longer. But the nurses try to make me feel like I'm comfortable or something. They compensate with me.
Okay.
But yeah, so sickle cell is a deep thing for me. So it's and then sometimes I'm it's I don't have it because of how my health is, and I'm probably the only one that's out here that's surviving.
Mm-hmm. But you're not alone, and I know you know that.
I know.
You know that.
Yeah.
So you said there's some bad and there's some good. What's the good?
The good thing is, well, I just told you, Gary.
Okay. Okay.
The good thing is that it's I almost don't have it.
Right.
But when the pain comes, I try to be calm about it, but if it's overbearing, then I'm ready to go to the hospital or something like that.
Mm-hmm.
So
you're somebody, Peter, that always makes me feel proud every time I see you, because you're a fighter, and that comes along really strong with you. Dr. Khurana, or Dr. K, let's go ahead and get to the subject at hand. Transitioning of care for young sickle cell patients, that's our topic. The appropriate transition of the adolescent from pediatric to an adult system of care is very important, because a disruption in the continuity of care can produce problems that could have been prevented. Would you elaborate on why this is true?
I would like to take a step back and point out that transition from pediatric to adult health care is a relatively new challenge. Because of the improved comprehensive medical care over the years for children with sickle cell, more than 90% will now survive into adulthood. Compare that to the 1970s, when patients with sickle cell did not often live past their mid-20s. Now, decades later, the average lifespan is 40 to 50 years of age. So the need to transition from a pediatric to adult healthcare system and integrate into medical communities is new. To date, less than half of patients between the ages of 18 and 21 years with sickle cell actually transition from pediatric to adult hematological services. Clearly, there is much need for improvement in this area. However, the young adult sickle cell community is not the only one to experience poor transition. Successful transition is a national challenge faced by other patients with chronic conditions like cystic fibrosis or congenital heart problems, to name a few. A national effort is starting to emerge, and medical centers are working towards establishing a model to help provide continuity and coordination of a medical home for those between the ages of 18 and 21 years. Now, to specifically address your question, what happens when there is a loss of this medical home for older adolescents and young adults? As you may expect, these individuals are at increased risk for complications from sickle cell that could be prevented, poor quality of life, and even death. Complications include unnecessary progression of cerebral infarcts or overt strokes. For example, upon transfer to adult providers, individuals with strokes should continue to receive blood transfusion therapy. Interruption of transfusion therapy is associated with increased risk of overt strokes. And strokes, we know, impair one's ability to process information and learn new things, which means individuals may not be able to graduate from high school or college or attain a good job. Also, without regular visits with an adult provider in the outpatient setting, individuals suffer from more pain crises that require IV pain control. Large studies show that young adults with sickle cell have the greatest number of emergency room visits between the ages of 18 and 30, especially when you compare them to age-matched adults without sickle cell and compared to those with sickle cell who are younger than 18 but older than 30. And frequent visits to the emergency room mean missed days of school, work, or other important social engagements. Additionally, the psychosocial sequelae of these complications cannot be accurately measured. While we can document the number of increased risks for strokes or pain crises, it is much more challenging to document how these contribute to patients' feelings of anxiety, depression, and even in some cases, self-hate. This just emphasizes that we need to develop a reliable transition for patients, and that requires input from, of course, patients, families, and providers.
Excellent, excellent. You've touched on a couple of very key points there. Let's go a little bit further. Would you please explain the transition process itself? I mean, what has to happen in order to ensure that it is effective and successful?
Excellent question. The infrastructure for developing a reliable transition process for those between 18 to 20 years of age is an ongoing, multifaceted, vibrant process. But to ensure success, I think there are at least two key elements. Since transition can be a period of uncertainty and confusion due to a change of expectations and goals, the first key element is to evaluate transition readiness based on a patient's emotional maturity, disease knowledge, coping skills, and so forth. Social workers are an integral part of this process. They can perform psychosocial evaluations and provide necessary services through education and referrals. This lays the foundation to make that transition from a child and parent-focused orientation to one with an adult-focused health orientation. And achievement of this independence can come from knowledge of sickle cell. As medical providers, we educate patients through verbal discussions and written materials, so patients understand their type of sickle cell. For example, hemoglobin SS versus SC versus beta 0 thalassemia, etc., and the potential complications that they can experience based on their specific type of sickle cell disease. We also review the complications that they experience from it, for example, like acute chest syndrome, the rationale for taking certain types of medications or receiving additional vaccines, the purpose of different types of screening, for example, a urine sample or an echocardiogram. We also provide copies of labs to identify their baseline labs, such as hemoglobin, reticulocyte count, and bilirubin, and the significance of any deviations. The second element to ensure a successful transition is logistics, like health literacy and health insurance. Navigation of financial health expenses and insurance plans is novel for any young adult. These new adult patients may no longer be covered by their parents' health insurance plans, and that requires patients' effort to seek new alternatives, whether it be private insurance through an employer or participating in the Healthy Indiana plan for uninsured adult Hoosiers who are otherwise ineligible for Medicaid. Lapses in insurance coverage result in decreased reimbursement for care coordination, and care coordination is absolutely essential for transition of young adults with sickle cell. So all this learning is not a passive process. It requires patients to be active participants. The medical team and community can serve as important resources and work together to help instill that motivation for patients to be proactive.
Based on that, what you have said, it is a very complicated process that really needs a lot of organization, coordination, planning, and different elements coming together to make this all work. Also, something you said, I know that we have actually experienced with our guest in the studio today regarding the change of insurance and an impact that that's had on them and their transition process, and we'll probably hear a little bit about that. That's a great answer. Thank you so much for being so clear and concise about what is supposed to happen. We also know that it doesn't always happen that way, but that's the perfect way, if you will. So thank you for that. We're going to take a break, and then when we come back, we're going to talk with Kori and Sheryl and Peter and get their side of the story of transitioning when we come back. Sickle Cell Action Network Internet Radio Show. My name is Gary Gibson, and we are talking about transitioning to adult sickle cell care with a great panel of guests. We're going to ask Kori Singleton, who was on our show last week. She made a statement that got her on the hook for coming back this week. And last week she said that she could talk for a long time about transitioning. And that's why we asked you to come back on the show today, Kori. How would you characterize your son's transitioning experience? Was Lathan's transition smooth or not so smooth, and why is that?
There was nothing smooth about it. Unfortunately, going into adult care is a gigantic step into a whole new world. His first visit, we were in the ER for about 4 hours, and although they had all of his transfer information, they treated him how they felt he should be treated versus how he had been treated prior. We sat in the emergency room for 5 hours. They would not call his primary care doctor or his hematologist. They made choices that only made him, 1, angry, 2, stressed out, which only intensifies the crisis. So, of course, I do my best to be polite and respectful. Perhaps my tone may change, but I don't think that they don't understand that no matter what their opinion is, they should try and stay with the same regimen that they know, the same care they have been getting for years. Whether they're new to you or not, if they're new, be concerned, pick up the phone, call the doctor. Don't just make decisions on your own. As long as it takes for you to get to know your pediatrician and all of the doctors and the nurses at the hospital, it's the same extent. It's like a whole big drop-off. You're starting all over from the beginning, and it takes a toll on the family. It takes a toll on their health. It's a very stressful transition, and there are so many different things that can be done to fix it.
Okay. It can be stressful. It was stressful for you. You have some ideas about things that could be done to fix it. What are some of those ideas?
Well, I think that if the doctors communicate prior to transitioning over, speak to each other, send the records, pay attention, look at the records that are in the system for your patients. You don't have to get to know them in one visit, but at least get to know what's in those records. To just take 5 minutes. It's going to take you 5 minutes to consult with someone to find out what they need in order to try and get them comfortable while you research a little bit more. Communication is 100% key. We can make this so much easier with communicating, and we can make it a lot easier if there's better knowledge at the emergency room level, which was a very good mention from Dr. K when we were speaking on the break. So communication. Parents, make sure you stay there and stay on top of them until they figure out that the same thing that goes on upstairs in the hospital needs to go on downstairs in the emergency room. Half the patients you can probably get out of there. If you take 5 minutes to read what's going on with them, that emergency visit can actually send them home versus making them stay.
Mm-hmm. Mm-hmm.
So then you get upstairs and still have to go through the wait and the communicating, the lack of communication. So in order for the transition to happen, it's strictly communication. Insurance, I mean, no disrespect to anything that was said. Insurance, all of that stuff, the patients will be treated. They're in your system. That's all that matters. That's what's important.
Mm-hmm. There is obviously a lot of passion coming out from you at this point, so this is a very important matter for you. Passion, emotion that I'm reading. So why is that, Kori? Where's this passion coming from?
You watch your child sit there for 5 hours with no, hope in ahead at all. Waiting on someone to stop giving them the same dose of medication that's doing absolutely nothing, or you're not trying to help it.
Mm-hmm. Mm-hmm.
If you look in his record, it'll tell you what they've done prior. Try it.
Right.
It's not a hard thing to do. To read someone's file is not hard to do.
Right.
So I guess that's the most annoying part, is that you sit there, and I have a very patient child. He's patient. I'm probably not so patient. He's very, very patient with doctors and nurses. It is not fair. It's not fair to any sickle cell patient to be in that much pain for ignorance of a physician. That's very unfair.
Yes, it is. And for those that are listening that maybe don't have sickle cell, or you're listening by chance and you don't know much about it, what's really good about Kori's remarks is that it gives you a sense of how difficult it is for a caregiver to participate in this process, to watch someone in agonizing pain being treated or not treated properly, not treated expeditiously, or whatever. And I think a lot of the pain that I see coming from you is the result of watching your son in pain.
Yes, that, and watching doctors and nurses walk around as if it's okay. Just give us a minute, give us an hour. The doctor will be back. We have to wait for him to change it. You know what? Call me at home when you're ready for him to have his other dose. That's not going to do anything.
Mm-hmm.
Instead of us sitting here, and I feel like he's being tortured.
Right.
It's wrong. It's not fair.
Right. Sheryl, you're shaking your head, and how would you characterize Peter's transitioning experience? Was it like Kori's, or was it smooth or not so smooth? And
Peter's
why is that?
transition was a little bit different, and I keep remembering his hematologist saying that Peter's case is so different from the other sickle cell children. Peter had actually had 5 strokes and 2 major brain surgeries. He wound up with a condition called moya, where the blood vessels in the brain constrict, and they found this through a transcranial Doppler that they do when he was at Raleigh Hospital. He would go to school and come home and could not remember the lessons or anything that he had learned in school that day. So eventually, his freshman year going into high school, they had to do major brain surgery, and he had 2 brain surgeries. And so his hematologist kept him close. I mean, they transitioned him out from Raleigh Hospital to adult at the very last possible moment.
Okay. So they kept him as long as they could.
They kept him as long as they could, and when he transitioned from Raleigh Hospital they transferred him over to IU, where they could kind of still keep an eye on him. He had the same, he gets apheresis, like the cancer patients do. So he gets 8 units of blood put in and 8 units taken out at the same time. He has a double ported cath in his chest, and he gets this done every 6 weeks.
Right.
To take care of the sickling blood. and it also prevents him from having further strokes
Mm-hmm.
or sickle cell crisis. And the same team that took care of him at Raleigh Hospital was also doing this procedure at the cancer hospital over at IU.
Okay.
So he was able to transition with the same people he's been with for the last, I don't know what, 5-10 years.
So his transition was smooth.
Yes.
That's great.
Now, when we talk about insurance, because my husband retired, our insurance needs changed. I work for the city, and our insurance is with a different hospital. So, which has to be his primary insurance because he's under 26.
Right.
So, guess what? We had to change hospitals.
And that,
That transition was a little bit different.
okay.
And we're still kind of working with that transition team. They still have to do the apheresis, but they don't have the exact same type of setup that the other hospital had. And they do it in a place, if I'm not mistaken, where they do dialysis at.
Okay.
The people who actually do this procedure with him are not people who, I don't think they're used to doing it all the time. So
Okay.
there have been some difficulties. Even once he had to go in at the other hospital to get his port changed, and he had what they thought was an infection, they decided to send him upstairs, put a temporary port in, and because he's over 18, they failed to let the people in the waiting room who were waiting on him know. And they thought he could just handle it on his own. They thought he was an adult, but because of that very reason, his father and I decided that we would be the medical guardians, and we went and had guardianship done. So now they're required to converse with us on his medical care.
Okay. Do you think that's made a difference?
Yes, it has, especially when I bring it to their attention.
Okay. Okay. Peter, it's your turn. So how would you go ahead and give us your perspective about the transition process that you've been through?
Well, to be honest, I don't like it.
Okay. I want your honesty.
It's been a tough road, and
Tell us why.
I'm getting used to doing everything by myself, making the calls, going in by myself, signing papers by myself. I realize that I'm getting older, and it's really tough because I have to like really think about what I'm going to do next, and what is it going to be like, and am I going to make a mistake or not?
Mm-hmm.
So basically, it's hard. It's just hard.
I understand. Dr. K, so you've been listening to the goods and the bads, if you will. As a practitioner, do you have any thoughts about what you've just heard?
I think transition is definitely a complex process. And to first respond to Kori's passionate response, first off, thank you for your passion, because it's passion like that will help drive change and recognize that there is a need for improvement.
I agree 100%.
And then in regards to your comment about the insurance, I was focusing on more or less the outpatient setting, because I want patients to know who their available providers are so they can choose someone who is going to be the most knowledgeable adult provider for sickle cell. And yes, anyone who seeks medical care in the emergency room, they will receive treatment regardless of insurance. But the focus for adult sickle cell care should be what can be done to prevent it and what things can be done to treat in the outpatient setting. So that's what the focus of the insurance question was. And you also brought up there is definitely a need for education and awareness among providers. I know as we are trying to transition our patients from Riley Hospital children to adult providers, we are actually working with developing individualized portable medical summaries that documents the type of sickle cell, all the complications they've had, and what needs to be done moving forward. So that way, if an adult provider is still in the process of learning of how to take care of a patient with sickle cell, they have all this information already laid out in front of them when it comes to screening and preventative care measures. Then when it comes to seeking IV pain control in the hospital setting or the emergency room setting, we are also working on developing individualized pain plans. And that comes down to what you had mentioned, there needs to be good communication. Even though we do have electronic medical records, it certainly does take time to go through them, and sometimes they're not always accessible. So by having that copy with the patient, I think that will certainly help so they can present it forward. This is not a perfect system, but I think the combination of some written documentation and having the patient learn to be their own advocate is going to be a step forward. And then getting back to Peter's comment about learning to be more independent and fulfilling their own prescriptions, it seems like you did have the chance to acknowledge how important it was and be somewhat prepared for that transition. I am curious, and I'm going to ask you a question if you don't mind. Based on what you have gone through, what do you think is going to help when it comes to self-education, for example, like learning how to fulfill your prescriptions and navigating the process? Do you think, meeting ahead of time with adult providers before officially transitioning would help? Would you like to talk to other patients who have recently transitioned from pediatric to adult clinics? Do you find reading pamphlets, brochures, or given the young age group online webinars would be more helpful for those details, or even attending group events that discuss how to do this, or something completely different?
Well, on the reaching out part to the patients, I would love to do that. I like talking about myself a lot. As you can see, but I try not to be so cocky or whatever, or talk about myself. So on that note, I would like to see what other people are doing for that, and like I'm a great listener when it comes to other people. But that could be something I could do.
That would be wonderful. We are actually working to try to develop a transition day for our teenagers, so I will be recruiting you to be able to come use your experiences to say what's going to help make it a smooth process. And it certainly is not cocky when you use your own experiences to help others.
I try not to be, but...
We're having a great conversation about transitioning to adult sickle cell care here on the Sickle Cell Action Network on RadioNext.tv, the Cool Groove site. We're going to take a break, and when we return, we'll continue this great discussion.
Hi, I'm Gary A. Gibson, your host for the Sickle Cell Action Network Internet Radio Show. If you are impacted by sickle cell disease in any way, whether you are a patient, a caregiver, or a friend, you need to join me every Tuesday at 4 p.m. Eastern Time. I promise that you will find our show to be full of information, perspective, and opinion about all things sickle cell. See you Tuesday right here on RadioNext.tv, the Cool Groove site.
Welcome back to the Sickle Cell Action Network Internet Radio Show. The Sickle Cell Action Network show is sponsored by Ms Therapeutics, a publicly traded biopharmaceutical company headquartered in San Diego, California. MAST is currently leveraging the molecular adhesion and sealant technology platform derived from over 2 decades of clinical, non-clinical, and manufacturing experience with purified and non-purified pelaxamers. MAST has developed a drug called MST-188 as a candidate for serious or life-threatening diseases with significant unmet needs. Among those needs is the treatment of sickle cell disease. MAST is currently enrolling sickle cell patients in a clinical trial known as EPIC. EPIC stands for Evaluation of Purified Palaxamer in Crisis. If successful, EPIC could result in the first treatment of its kind to treat sickle cell disease patients while they are in crisis. The EPIC study aims to determine whether MST-188 can shorten the duration of a painful crisis. MST-188 is an investigational drug that has not been approved for commercial sale in any jurisdiction for any use. MST-188 potentially improves oxygen delivery and may help keep blood vessels from becoming blocked and more obstructed. It may improve blood flow by stopping cells from grouping together. It may also reduce inflammation and may restore cell membranes and give damaged cells time to heal. Interested patients should know that EPIC participants will receive their normal pain treatments during crisis and that there is no cost to participate. Interested patients should also know that participating in this study could not only help themselves, but might also help future generations of those yet to be born. If you are interested in learning more about the EPIC study, please visit www.theepicstudy.com. Thank you to Mass Therapeutics for sponsoring the Sickle Cell Action Network Internet Radio Show. Speaking with Dr. Monica Khurana and Ms. Kori Singleton and Sheryl and Peter Richardson, we're going to continue our discussion about transitioning to adult sickle cell care, and we're going to go back to Dr. K here and ask her this question. Dr. K, abrupt, unplanned transitions are likely to work poorly. And I think Kori can probably testify to that based on what we heard from her before the break. Some say that the process should begin as early as 12 years old. Do you agree with that?
I do agree that abrupt, unplanned transitions are less likely to be successful. Change can be an intimidating process for anyone, so preparation can make the process less scary, but that also takes time. It's also important to underscore that transition is not merely a handoff from a pediatric provider to an adult one. It is a transition towards knowledge about one's medical condition in order to maximize one's quality of life and be a confident advocate for oneself. Attainment of this lifelong goal can start at any age. In other words, transition is a continuum. So I would also agree that a formal process starting at 12 years of age to include transition readiness, like understanding the disease knowledge, recognizing emotional maturity and coping skills, etc., are necessary parts of this process. In actuality, this is something that is already done, albeit unconsciously. For example, this might include ensuring that the child knows that he or she has sickle cell disease, or encouraging them to pay attention to what things trigger a pain crisis, like going outside in the cold without a jacket, or allowing them to be more autonomous in reminding themselves to take medications like folic acid every day. Even asking the question, "What would you like to be when you grow up?" is part of the process. This question is twofold. On one hand, children realize that sickle cell disease may limit their options. They may not be the next famous NFL player or lead mountain climbers at Mount Everest. On the other hand, it also helps them recognize that they need to pay attention to their health if they want to accomplish their career goals. A 12-year-old patient can understand that if she does not take her iron chelation medicine, she will spend more time in the hospital, and that interferes with her plans to become a hairdresser, as we have one patient whose career aspirations is to become a famous hairdresser.
Right.
So providers recognize that different age groups process risks differently, and they have different priorities. If the process starts at 12 years of age, then we ensure that the transition readiness and transition goals are age appropriate, and then we are ready to adapt depending on how quickly the child emotionally and intellectually develops.
Great answer. Great answer. Sheryl, how old was Peter when his transition process started? It wasn't 12, was it? And do you feel that it should have been earlier or later, and if so, why?
Well, in the manner in which Dr. K talks about him being aware of his disease and becoming an advocate for himself, he probably started around 12 or maybe a little bit earlier, maybe around 10 years old. But when we actually did the final stages of the transition, he was around 22 years old.
Okay. That's the final stages, you say?
Mm-hmm.
Okay, so when did the other stages start? About?
Around 12.
Around 12.
Mm-hmm.
Okay. So it was about a 10-year process.
Yeah.
Okay. And I think that's an important note. Transitioning is a process. It's not an event. I have a good friend of mine that always says that, and it's so true. It's a process. It's not an event. So a process is something that takes time to take place and to develop. Kori, how old was Lathan when his transition process started?
18.
18.
And he had no choice but to do it because he went off to college.
Okay.
So it actually did well, surprisingly well, because he was at a university hospital. It was when he returned home to transition from University of Arizona hospital to the Good Samaritan Hospital in Phoenix. That was the really very bad transition. However, I think that because they're college students, they're still considered young adults, still children. Mm-hmm. So if it were up to me, I would have waited till he was I would have waited till he was 24 because he's still seeing his pediatrician until yesterday.
Really?
Yes.
Okay. Well, that's something that's going on too as we talk about this, and that there is a push, I think, in some hospitals to push the patients out, some of the children's hospital to push them out maybe a little earlier than the parents would like that to happen. And I think that is a trend that we see in certain parts of the country. So maybe we shouldn't do that if it's at all possible. Maybe we should let them stay a little longer and ensure that all of these other steps of a transition process are taking place before we push them out. And I think we touched on how it's a multifaceted event. It's or a multifaceted process. And in that process, we've got to engage social workers. We've got to engage other parts of the healthcare profession. We've got to engage families. We've got to engage educators. We've got to engage everybody, really, to make this work effectively. So sometimes that takes time, and then just pushing somebody out just because they've reached the age where they don't want to take care of them anymore maybe isn't the best solution. Dr. Khurana, what are some of the things that can go wrong for sickle cell patients if a proper transitioning process doesn't take place?
I think the response to this question parallels the response to the question asked earlier about what needs to happen for a successful transition.
Right.
So from a medical standpoint, the loss of a medical home for older adolescents and young adults results in increased risk for complications from sickle cell that could be prevented, the poor quality of life, and even death. Think of all the hard work done during childhood to minimize stroke risks, like coming for a transcranial Doppler and receiving monthly transfusions. All that hard work goes down the drain because the patient now has the same risk of stroke as she did before the transfusion started if there is an interruption in terms of treatment.
Right. By the way, let me stop you. We've mentioned it several times, and the words transcranial Doppler, I think everybody in this room knows what they mean, but some of our listeners may not understand that. Would you explain that real quick?
Sure. So if you think about an ultrasound where you are using a gel and a probe to transmit waves and images, and the person reading those images can look at the blood vessels and the flow of how fast the blood is in those vessels. And depending on how quickly the blood is flowing, we can get an idea about a patient's risk of stroke for the next 3 years.
Right.
We have specific parameters with how fast the blood is flowing to help us determine that risk.
Okay. So if it's flowing faster, if I understand, if it's flowing faster, the risk is higher?
That's correct.
Okay.
Our parameters are if the velocity is 170 meters per second or less, that's normal.
Okay.
If it's greater than 200 meters per second, that's abnormal, and there is a very high risk of stroke, about 40% in the next 3 years, so we definitely would want to intervene.
Right.
And then you have that gray zone between 170 and 200, and that means we need to follow the patient very closely.
Okay. Thank you for that, and I'm sorry to interrupt you, but I think it's important for people to understand that because it is a very important tool in fighting sickle cell.
And then from an economic standpoint about what happens when patients do not successfully transition, patients then end up seeking medical care through the emergency department as opposed to outpatient settings, and then the problem becomes an increased healthcare utilization and expenditures, and that diminishes fundings for things like necessary transition programs. And then, as previously mentioned, from a psychosocial standpoint, there's an increased emotional stress, not only from the unpredictability of sickle cell complications, but also from the impairment to integrate into activities such as college, work, or the community. While all this sounds very dire, it's not permanent, and by working together, we can slowly implement change to make transition from pediatric to adult health care successful. Sickle cell does not have to be a debilitating disease.
Thank you, Dr. Khurana. Very good explanation. We really appreciate that. Sheryl, from your perspective, what would you say were the highlights of Peter's transitioning experience?
It taught him how to become more of an advocate for himself. When we were actually working with the hospital and the social workers, we were able to transition very easily from the children's to the adult in the first transition. So now in the second transition, like I said, we're still working on that.
Right.
He is being seen out at the hemophilia, I guess they call it hemophilia clinic. Yeah, thrombosis clinic, where they have a huge amount of patients who are hemophilia and sickle cell.
Yes, they do.
And the care is a little bit different. It's maybe not quite as one-on-one of what he's used to.
Mm-hmm.
And we've even experienced that probably over in the hospital itself.
Okay.
But Peter and his father could tell you more about that because I haven't had a lot of experience over there.
Okay.
Now that my husband's retired, he gets to go.
Mm-hmm. Okay. Peter, would you agree with what your mother just said? If not, what would you say the highlights were?
Well, it's like my mother said, but I just don't like, what I don't like is switching back and forth between doctors.
Okay.
I've had that like 3 or 4 times.
Uh-huh.
It takes a lot for me to get used to personalities
Mm-hmm.
in doctors.
Mm-hmm.
And if the personality is just plain not no reaction or anything like that, then that tells me that you don't really care, and
Mm-hmm.
I'm just sitting here wasting my time,
Mm-hmm.
and I'm not gonna like you.
Mm-hmm.
So it's a lot. It's different for me.
One of the things that I sense too with you, and it's true with a lot of the other folks that are in your shoes, is that it's important to have a trusting relationship with those that are taking care of you, right?
Yep.
I mean, you really want
It
to trust
is.
those doctors, and when you have to switch back and forth, it makes it hard to do that,
Mm-hmm.
right?
Yep.
Yeah, okay. Kori, same question. What would you say were the highlights of Lathan's transitioning experience? You did tell us some of the tough stuff, but were there any good things?
Well, there were no good things in Phoenix, so let's switch to when he transitioned here
Okay.
to Indiana, which I will have to say that was probably the best transition because you helped me tremendously, and I pretty much got him all set up, and I will never forget Dr. Tondra actually called me back in Phoenix before I even moved here to just to find out some things about me, find out some things about Lathan, which beyond shocked me. But I was very impressed. So once we got here, he saw Dr. Tondra, and I will say that IHP was excellent for him. He loved all of the doctors, Dr. Kim, Dr. Tondra, the attendants,
Mm-hmm.
because there is one attendant from IHP
Mm-hmm.
at St. Vincent's all the time. So that actually made me feel really good, and I was very comfortable when I moved here. So that was a good transition. First hospital stay, probably not so good, but the communication with the provider with his doctor was fantastic.
Okay.
And I love Dr. Tondra, and I'm bummed that he's not there anymore.
Yeah. Okay. Great discussion. We're going to step away, take a break, and when we come back, we'll continue the discussion and start wrapping up our show. Thank you for joining us on the Sickle Cell Action Network Internet Radio Show here on RadioNext.tv, the Cool Groove site. We are sponsored by Mass Therapeutics and brought to you by Martin Center Sickle Cell Initiative. Martin Center Sickle Cell Initiative is a 46-year-old community-based organization that provides services to people that have sickle cell disease. We always need your support. We are in the middle of our annual campaign. We have 2.5 weeks to go before the campaign is over, so we would always appreciate some donations. All you have to do is go to www.themartincenter.org and click on the beautiful red donate button. We provide services to people with sickle cell disease, including a food pantry, a support group, transportation assistance, financial assistance, and referral services. We also spend time out in the community doing community outreach and education, providing information about sickle cell at health fairs and in group presentations. And finally, we spend a lot of our effort on advocacy, trying to make a difference for those that must live with sickle cell, and the Sickle Cell Action Network is a part of that advocacy. Thank you for being with us, Dr. Monica Khurana, Kori Singleton, Sheryl Richardson, and Peter Richardson. We're going to pick up our discussion and start winding down as we talk about transitioning to adult sickle cell care. We're going to ask Sheryl, what are some of the other problems or obstacles that we may not have mentioned yet that you encountered during transition? And we ask these questions because we want people to know what to look for. We assume that there are listeners out there that are on the verge of going into transition or just getting started, and you are a source of information to help them. So what kinds of obstacles might you have encountered?
I had to really do my research, and obstacles that I thought about, or I went to the support group and I listened to other people around me who started to tell me about their obstacles and their horror stories. And I kind of made decisions based on some of the things I was hearing. For example, some of the children, once they turned 18, would go to the hospitals, and the medical people would tell them, well, you can just sign off on this. You can decide for yourself. You don't need the guidance of your parents. And then the kids would be maybe up in the hospital with a crisis, and the parents didn't have any information. And sometimes the hospital felt like they didn't need to give it to them. And I had decided that was not going to happen to us.
Okay.
And so I sought legal counsel and took care of that, and we picked up guardianship of Peter.
Okay.
And we thought we would hold on to that until he was able to advocate for himself.
Okay.
We just went through and went to a lot of disability fairs. Talked to several social workers. I have had an educational consultant that I hired when Peter had his first stroke to actually help walk me through the educational system, and she was able to help walk me through some of the medical needs because she had previously worked with chronically ill children.
Okay.
So I would say just go out there and try to find your resources and talk to other people.
Okay. Peter, is there anything that your mother might have missed that you experienced during your transition obstacles?
No, she got it right down on the dot.
Okay. All right. Kori, what about you? Were there any obstacles that you encountered that you didn't already mention?
No, I have to go with Sheryl on they want so badly for these kids to give consent and try to keep you uninformed. So that was a big one. For me, I had to make them understand that he may be 18, he may be 21, but I am his mother, and I'm not going to go out and do a whole lot of extra work to do what I'm supposed to do, regardless if he's 40, if he's 50. As long as he is down for the count, somebody needs to be there to speak for him.
Mm-hmm.
So I've made it a point to, I know for a while there I was trying to get him to speak up and be a little bit more vocal.
Mm-hmm.
So I would tell him what to say as soon as they walk back in the room.
Okay.
So that's a very big problem.
We've had several comments that were made that are worth repeating, and we were, as we wrap up, we'll ask for our panelists to give us their words of advice. But so far, we have spoken about the importance of communication. Cannot over stress that. The importance of communicating throughout the process, the importance of looking at the patient's records, the importance of self-advocacy, ensuring that the patient is able to advocate for themselves, as well as the importance of doing your research. So these are, I think, critical elements to ensuring that you are able to develop and participate in a very successful transition process. So now it's about time to ask for advice. Kori, what advice about transitioning do you have for other parents who might be listening right now? In addition, anything that you haven't said already, or you can repeat yourself.
I'm going to
if you
repeat
want
what I said last time, of course.
Right.
Parents, stay with them. I don't care how old they are in that transition. Stay with them. Have someone with them. Everyone thinks that...
So wait a minute. When you say stay with them, you mean literally.
Literally.
Right, exactly.
Literally.
Be clear about that.
I'm very glad. I mean, tag team. Do whatever you have to do to make sure that they're taken care of in that transition, because they don't know them yet.
Right.
You know them. So, I mean, I would definitely say tag team, somebody with them all the time, the best that it can be.
You mentioned, I think last week, you mentioned that your son was in rooms sometimes with other sickle cell patients and there was nobody there with them, right?
Right. And their parents, I mean, I understood they had other children. I had Lathan, it was just he and I, so on several occasions I told the parents, I got your kids, and let them feel good about being able to leave them there when they don't have a choice. That takes a little bit of worry off of them. And I'm going to pay attention to what's going on, even with that child. So it's a team effort. I've even asked once for them to move a child into the room with Lathan because the mom couldn't be there. So it's all about someone. It doesn't necessarily have to be you, but have someone with your child at all times, because they sleep. They don't know when they get into that sleep they're so exhausted from being in pain for so long. They don't ask for anything. They forget to ask for the things they need. So we need to be there. Someone needs to be there to make sure that they're doing what needs to be taken care of. Simple thing, water. They're not always going to just wake up and say, I'm thirsty. They'll roll over and go back to sleep.
Right.
Dehydration right there. So it's just all about helping and staying with them until everyone knows we're in a good spot now. We're comfortable. Once everybody's comfortable, I still say stay as much as you possibly can, but you do have to let go at some point, a little bit.
Any other advice?
Communicate, stay calm, and be nice to the doctors and nurses the best that you can. And that's all I have on that one.
Okay. Well, it's always true to be as nice as you can to the doctors and nurses because they have so much control, and you certainly want them to be friendly. You want them to want to help you, so you want to do everything that you can to ensure that that's true. Cheryl, from your perspective, what advice would you give to any parents that might be listening right now?
I would copy Kori's. Always make sure someone is with them, because I don't remember a time when Peter was ever alone.
Okay.
And so, fortunately, my family is here in Indianapolis, so that includes grandparents, aunts, I remember my cousin taking a half a day of work off to come down when he was having a blood transfusion, and I had to be somewhere else. And Peter was at work, so
you had a great support system.
I had a great support system. Another thing that I had learned from my educational consultant was get your hands on their medical records. Get your own personal copy, if you can, of their medical records. And if you're in the middle of transitioning from childhood to adult, and you're in the process of completing that last IEP, you can get them free from the hospital to go along with the IEP. So he'll have those when he's ready to transition on to college or whatever else we're going to do next, because it's going to be needed. And if you wait until after that point, they'll charge you so much per page for it. And Peter's has to be, a couple of inches thick. So.
Okay. Peter, to others that are out there listening that are patients your age or younger, what advice would you have for them?
I would have to say that we need to stick together and know each other. We need to support each other and basically help each other out, because it's getting to the point where sickle cell is getting ridiculous. And some of you guys might feel like you're left out or alone, but you're really not. It's a lot of us out here with the same issues, and hopefully you'll grow into you'll grow out of it eventually, of being silent.
And I think what you're saying is very important. It's important to bond together. There is a tremendous amount of strength that you as an individual can get when you feel that you are bonded with others that are facing your same issues.
Yeah.
So you're talking some really good stuff, Peter. And so one thing that we might want to do, and we try to do it at Martin Center Sickle Cell Initiative when we can, is ensure that people with sickle cell know each other and get to know each other. Not only know each other, but get to know each other, and in doing so to bond, because you do get strength from that bond. So that's very good advice, Peter. Thank you. Dr. Khurana, I'm going to ask you a two-part question. What advice about transitioning do you have for patients and parents that might be listening?
Well, mentioned was the importance of parental involvement. Parents are role models. It's important that parents prioritize regular checkups and preventative care even before the transition process begins. Then during the transition process, parents can help identify which areas that they think their children may struggle with, so the medical team can individualize that process. Everyone goes through uncertainty and confusion and experiences that differently, and parents have a special insight into their children, which we value as medical providers. Also, parents can help their children prepare for the clinic visit and encourage them to ask questions directly to the provider. After all, there's no such thing as a dumb question. Asking questions helps establish independence and motivation for learning about how to be healthy.
Thank you. And then the second part of my two-part question for you, Dr. K, what advice about transitioning do you have for providers that might be listening?
Transition from pediatric to adult healthcare is an emotional process not only for patients, but also for providers. Pediatric providers have a hard time letting go of their patients too, because so much energy has been invested in preventing complications or treating them and maximizing quality of life. Beginning the transition process early and working as a multidisciplinary team will allow patients to benefit from all those years of hard work towards good health care. Also, the comprehensive sickle cell team at Riley Hospital for Children is an available resource for Indiana providers 24/7.
Great. So really this is a team effort. Transitioning is a team effort. And I guess my final question is, who's in charge of the team? Who's the quarterback? Who's the coach? Anybody?
Me, I would say.
You would say you, the parent?
Oh, yeah.
Yeah. Okay. Cheryl?
I would say the parent.
The parent? Peter? Who's the coach? Who's in charge here?
Oh, you really don't want to ask me that.
Okay.
I guess it'll be, if I'm alone, it'll have to be myself. But if I'm with my family, it'll be my mother or my father.
Okay. And Dr. K?
It's everyone, because you can't be successful without the other. It's the patient, it's the parent, and it's the provider.
Perfect. It's a team. It's a team effort. To my guest, Peter Richardson, Sheryl Richardson, Kori Singleton, and Dr. Monica Khurana, thank you so much for being with us today. Any last words or parting thoughts any of you have?
Everyone with sickle cell, please stay inside.
Yeah.
That's all I got.
It's cold.
It's cold. It's
cold.
cold.
Very.
Well, remember at the opening of the show when we did the Sickle Cell News Update, we talked about the U.S. News and World Report story on the do's and don'ts of the cold. And obviously, stay in if you can for as long as you can when it's really cold. It's time for us to close our show. Thank you for being with us today. Again, we're sponsored by Mast Therapeutics, and we are grateful for their sponsorship. We are a service of Martin Center Sickle Cell Initiative. My name is Gary A. Gibson, and I am your host. And I'd like to leave you with a closing thought or two. I'm going to start, as I usually do, with a closing quote. And the quote goes like this: "With confidence, you have won before you have started. With confidence, you have won before you have started." These are the words of Marcus Garvey. Marcus Mosiah Garvey Jr. lived from August 1887 to June 1940. He was a Jamaican political leader, publisher, journalist, entrepreneur, and orator who was a staunch proponent of the black nationalism and Pan-Africanism movements. Among other things, he is known to have founded the Universal Negro Improvement Association and African Communities League. The Merriam-Webster Online Dictionary says that confidence is a feeling or belief that someone or something is good or has the ability to succeed at something. That's a pretty straightforward definition, but I think it has a tremendous amount of meaning, particularly when it comes to helping people believe in themselves. Throughout history, there is an unlimited number of people who have achieved much simply because they had confidence in themselves. In fact, the majority of actors and actresses, musicians, sports legends, and political figures became household names because they were driven by ambition, and their ambition was bolstered by their own self-confidence. If you have sickle cell disease, it is possible that you might think that you are not in the same league as Oscar winners, Grammy winners, MVPs, and presidents. If you think that, you are right, because it is probably more accurate to say that those people are not in the same league as you. Yes, they've had to overcome many obstacles on their rise to stardom, but they haven't had to endure and conquer a chronic condition like the one you have. They haven't had to wake up every day wondering if they could get through the day without more debilitating pain. They haven't had to spend inordinate amounts of time in hospital emergency rooms fighting with doctors and nurses in order to get the appropriate care. Nor have they had to fight the ongoing battle of going on and off of powerful painkillers. These are things that you can do that I am certain that many of the world's superstars can't do. I say these things because I want to encourage you to have confidence in yourself. Your limits have been tested over and over again. Each time that you are tested, you've been able to rise above and stand in line for more. You serve as an inspiration to me and many countless others who watch you in amazement. To us, you are among the best examples of strength, courage, bravery, and determination. I only wish that more people knew more of your stories, because your stories show just how powerful a human being can be. If you do have sickle cell, take a moment to reflect on these things. Try to do it objectively. If you can be objective, you will soon realize that you are, in fact, an amazing human being. You are, in fact, someone who can move others to understand that the real stars are not those we see on Entertainment Tonight, on ESPN, or on C-SPAN. No, the real stars are those individuals who can endure and maintain through some of the toughest tests that life has to offer. No, my friend, the real star is you. So take a moment to reflect on these thoughts. See yourself as you really are. Not someone who is sickly, but someone who is strong. Not someone who is needy, but someone who gives freely to others in ways that may only be seen subconsciously with spiritual eyes. I've said it before, and I'll keep saying it over and over. You are a source of inspiration to many. That should be reason enough for you to see that it is okay for you to have confidence in yourself. I and so many others believe in you. It's okay if you believe in yourself too. If you can do that, you will see that you have won before you even started. That's our show for today. Please join us again next week, same time, same station.